Every adult over 60 in the United States is doing something today that their kidneys are paying for. Not occasionally, not seasonally, but every single day as a completely normalized part of daily life that no physician has ever flagged as a kidney risk in any routine appointment. It is not a food, it is not a medication. It is a behavior so ordinary and so universal that its connection to progressive kidney damage has been systematically overlooked in Western clinical practice for decades, while the research documenting that connection has been accumulating in Japanese and Korean nephrology literature since the late 1990s. The Japanese Society of Nephrology published its first formal clinical guidance linking this specific daily behavior to accelerated kidney function decline in adults over 60 in 1998, 27 years ago. That guidance has been updated 3 times since, most recently in 2022, as the longitudinal evidence base has grown from preliminary association studies into one of the most consistently replicated findings in geriatric nephrology across Asia. A version of that guidance has never appeared in an American clinical standard. By the end of this video, you will know exactly what this behavior is, the precise biological mechanism through which it damages kidney tissue in the aging body, the 5 steps that stop and partially reverse that damage, and why the American healthcare system has no financial incentive to tell you any of this before your GFR reading drops below the threshold that opens the door to a $200 billion treatment industry. The habit is chronic mild dehydration, the persistent daily state of operating below adequate fluid volume that affects an estimated 37 to 40% of adults over 65 in the United States as a baseline physiological condition, not as an occasional oversight. Not severe dehydration, not the kind that produces dizziness, dark urine, and visible distress. Mild, chronic, persistent, below-threshold dehydration that produces no dramatic symptoms, and that the aging thirst mechanism, which declines in sensitivity by an estimated 30% after 60 due to hypothalamic receptor changes documented in research from the University of California, San Francisco, does not reliably signal. The human thirst mechanism evolved as an acute survival alert for significant fluid deficits. It was not designed to detect and correct the persistent low-level deficit that produces clinical kidney damage across months and years in an aging filtration organ that cannot repair itself once structural damage accumulates. Adults over 60 are chronically mildly dehydrated. They do not feel thirsty. Their kidneys are filtering blood with inadequate fluid volume every hour of every day, and the tubular damage accumulating from that condition is invisible, painless, and irreversible once it crosses the clinical threshold, which is precisely what makes it the most consequential unaddressed kidney risk in the aging population. My name is Dr. Jae Yoon. I have practiced medicine for 26 years, trained in Western clinical medicine and traditional East Asian integrative medicine, and I have spent a significant portion of that career managing chronic kidney disease in adults over 60. In my practice, I have seen patients with declining GFR readings who had no hypertension, no diabetes, no NSAID use, and no family history of kidney disease, the 4 risk factors their primary care physician had reviewed and cleared at every annual appointment. The variable that connected their kidney decline, identified only after careful history taking that a standard appointment rarely accommodates, was fluid intake. Every one of them was drinking fewer than 4 cups of fluid daily, every one of them reported no significant thirst, and every one of them had been told their kidneys were a little low on GFR without any clinical guidance about the simplest, cheapest, and most evidence-supported intervention available for slowing that decline. Water. Not a prescription, not a procedure. Water, at a specific daily volume, with a specific timing protocol, adjusted for the specific medications most of them were already taking that were making the problem worse without anyone having connected those dots. Before we go through the mechanism and the 5-step protocol, press the like button right now. I do not have a pharmaceutical company funding this channel. Without that like, YouTube buries this video, and the person who needs it most never finds it. With your like, this reaches 100,000 people. And somewhere in that number is an adult over 60 whose last GFR reading came back below 60, officially chronic kidney disease stage 3. and whose physician's guidance was to monitor it and return in 6 months. Press it now. Every week I release research your doctor has not had time to cover in a standard appointment. Subscribe so you do not miss it. And I deliberately left out one specific morning hydration timing protocol used in Japanese hospital nephrology wards for adults over 65 that produces measurably better GFR preservation outcomes than standard hydration advice. Tell me in the comments if you want me to cover it next. I read every single one. The kidney's filtration architecture requires a minimum circulating fluid volume to perform its core function safely. Each kidney contains approximately 1 million nephrons, the individual filtration units consisting of a glomerulus and a tubule, through which the entire blood volume passes roughly 300 times per day. The glomerulus drives filtration through hydrostatic pressure. The pressure differential between the blood entering the glomerular capillary and the fluid in the surrounding Bowman's capsule forces water, waste, and small molecules across the filtration membrane. When circulating fluid volume drops, as it does in chronic mild dehydration, two compensatory mechanisms activate. The first is antidiuretic hormone release from the posterior pituitary, which instructs the tubules to reabsorb maximum water from the filtrate back into circulation, concentrating the urine and preserving blood volume. The second is activation of the renin-angiotensin-aldosterone system, which constricts the efferent arterioles, the tiny vessels leaving each glomerulus, to maintain glomerular filtration pressure despite reduced circulating volume. Both mechanisms sustain filtration function in the short term. Across months and years of chronic activation, the tubular cells operating under maximum reabsorption demand and the glomerular vessels under sustained constriction accumulate structural damage, a condition called chronic tubulointerstitial nephritis that progressively and irreversibly reduces the kidney's filtering capacity with no pain, no external symptom, and no warning until the damage is clinically significant. The reason this mechanism is specifically more damaging after 60 than at any earlier age comes down to 3 biological changes that occur in the kidney with normal aging, independent of disease. First, nephron number declines. The adult kidney loses approximately 1% of its functional nephrons per year beginning in the 4th decade of life, meaning an adult at 65 has already lost approximately 25% of their baseline nephron complement through normal aging before any additional stressor is applied. Second, glomerular filtration reserve, the kidney's capacity to increase filtration rate above baseline under physiological stress, declines significantly with age, reducing the margin for compensating for reduced fluid delivery. Third, tubular concentrating ability declines. The aging kidney must work harder to achieve the same degree of urine concentration that a younger kidney accomplishes with significantly less tubular stress. An adult over 60 operating in chronic mild dehydration is asking a kidney with 25% fewer nephrons, reduced filtration reserve, and impaired concentrating efficiency to perform maximum intensity concentration work every hour of every day. Research from Kyoto University's Nephrology Aging Division, tracking kidney function trajectories in 1,040 adults over 65 across 15 years, found that adults in the lowest quartile of daily fluid intake showed GFR decline at more than double the rate of adults in the highest quartile, independent of blood pressure, diabetes status, and medication use. The 3 medications most commonly prescribed to adults over 60 compound the chronic dehydration mechanism directly and create a compounding kidney risk that no individual prescribing physician has typically evaluated in combination. The first is diuretics, hydrochlorothiazide, furosemide, chlorthalidone, prescribed for hypertension and fluid retention by reducing kidney fluid output. As we covered in our previous video on blood pressure medications and kidneys, a diuretic placed on top of a baseline state of chronic mild dehydration asks an already fluid-depleted kidney to excrete more fluid from a system that has insufficient volume to perform that work safely. The second is ACE inhibitors and ARBs, lisinopril, losartan, ramipril, which reduce internal glomerular filtration pressure systemically. In a well-hydrated kidney with adequate blood delivery through patent renal arteries, this pressure reduction is physiologically tolerable. In a chronically dehydrated kidney already operating with reduced hydrostatic filtration pressure, reducing it further through medication approaches the threshold at which filtration becomes mechanically compromised. The third is proton pump inhibitors, omeprazole, pantoprazole, taken daily by millions of adults over 60 for acid reflux management, which have been associated in multiple studies with hypomagnesemia, interstitial nephritis, and chronic kidney disease progression through mechanisms that compound the dehydration-related tubular stress already present. All three medication categories are independently appropriate for the conditions they treat. None of their prescribing physicians is reviewing their combined effect on kidney fluid dynamics in an adult who is chronically mildly dehydrated as a baseline physiological state. The Japanese Society of Nephrology's 1998 guidance and its subsequent 3 revisions were generated by a research program that had 2 specific advantages over the American clinical framework, within which this connection has been largely invisible. The first was a population-level tracking system. Japan's national health insurance data, linked to detailed dietary and fluid intake survey data through the Ministry of Health's annual National Health and Nutrition Survey, allowed researchers to correlate daily fluid intake patterns with GFR trajectories in adults over 65 across populations of hundreds of thousands of patients at a longitudinal scale that American research has rarely matched for this specific variable. The second advantage was a clinical culture in which preventive nephrology, the assessment and protection of kidney function before disease is established, is a standard component of geriatric care rather than a specialty referral triggered only by established disease. Japanese geriatric hospitals have maintained dedicated hydration assessment protocols for adults over 65 since 2001, including standardized daily fluid intake monitoring and targeted hydration counseling as routine components of both inpatient and outpatient care. The concept that a nurse should document daily fluid intake alongside vital signs for every adult over 65 under care, because the correlation between inadequate fluid intake and GFR decline is as well established as the correlation between elevated blood pressure and cardiovascular risk, has been standard Japanese geriatric practice for over 2 decades. It has never appeared in an American nursing standard of care document. The South Korean National Health Insurance Service published a cohort analysis in 2020, tracking 286,000 adults over 60 across 8 years, that produced a finding whose implications for standard clinical practice have not been adequately communicated to patients. Adults in the lowest fluid intake quartile, drinking fewer than approximately 4 cups of total fluid daily, showed kidney function decline at a rate approximately 45% faster than adults in the highest fluid intake quartile after controlling for age, sex, diabetes, hypertension, and medication use. 45% faster GFR decline from a single modifiable behavior that costs nothing to change. The study calculated that if the lowest quartile adults increased their fluid intake to the highest quartile level, the number of adults progressing from chronic kidney disease stage 3 to stage 4 over the 8-year follow-up period would have been reduced by an estimated 31%. 31% fewer adults reaching advanced chronic kidney disease from drinking more water. The pharmaceutical companies manufacturing the medications used to manage stages 3 through 5 of chronic kidney disease generated over $40 billion in combined revenue in 2024. There is no product to sell when the intervention is water at a specific daily volume. The 5-step protocol that stops and partially reverses the kidney damage mechanism of chronic mild dehydration is specific, sequenced, and built on the evidence base from Japanese and Korean nephrology research rather than the general drink 8 glasses of water guidance that appears in standard Western health materials without the clinical specificity that makes it actionable. Step 1 is establishing your current daily fluid intake with accuracy before attempting to change it. Most adults significantly overestimate how much they drink. Keep a written log for 3 days, every cup of coffee, tea, water, and other beverage, before starting the protocol. Research from the National Institute of Aging found that adults over 65 who self-reported adequate hydration were drinking, on average, 40% less fluid than they believed. You cannot correct a deficit you have not measured. Step 2 is calculating your personal minimum daily fluid target. The Japanese Society of Nephrology protocol for adults over 65 specifies a minimum daily fluid intake of 30 milliliters per kilogram of body weight, approximately 2 liters for a 65 kilogram adult, or roughly 8 to 9 cups. This is a floor, not a ceiling, and it excludes alcohol, which is a net diuretic. Adults on diuretic medications should discuss their specific fluid target with their physician, as diuretic dose and fluid intake must be calibrated together. Step 3 is timing distribution, the element of the protocol that most adults do not receive even when they are given a daily fluid target. Drinking the entire daily fluid requirement in the evening to compensate for inadequate intake during the day does not protect the kidney from the morning dehydration stress that accumulates during overnight sleep when no fluid is consumed for 7 to 9 hours while kidney filtration continues. The Japanese geriatric hydration protocol specifies distributing fluid intake across 6 to 8 scheduled drinking times. 2 cups on waking before any food or coffee, followed by 1 cup every 90 minutes through the day, with the final serving no less than 1 hour before sleep to avoid nocturia-related sleep disruption. The morning bolus on waking is the most clinically important element. Overnight, the kidney has been concentrating urine for 8 hours, while circulating volume has declined. Providing 400 to 500 milliliters of water immediately on waking restores filtration pressure before the renin-angiotensin system activates to compensate for the morning deficit, reducing the glomerular constriction stress that the first hours of each day otherwise impose. Step 4 is temperature and mineral content of fluid. Cold water delays gastric emptying and reduces the rate of intestinal absorption into circulation, producing a slower restoration of circulating volume than room temperature water. The Japanese protocol specifies room temperature water for morning hydration specifically. Adding a small amount of natural mineral water, or a pinch of sodium and a slice of lemon, to the morning bolus improves intestinal absorption through the sodium-glucose cotransporter pathway and reduces the proportion of consumed water that passes directly to urinary excretion without entering systemic circulation. Step 5 addresses the medication and supplement interactions that most adults on kidney protective hydration protocols have never been told to account for. 4 categories of common daily substances in the lives of adults over 60 are net fluid depleters that must be compensated within the daily fluid target rather than counted toward it. Coffee and caffeinated tea. Caffeine has a mild diuretic effect at doses above approximately 200 milligrams, roughly 2 standard cups of coffee, meaning fluid consumed in caffeinated beverages beyond this threshold is partially offset by increased urinary output. For every cup of coffee consumed beyond the second, add an additional half cup of water to the daily target. Alcohol. Even 1 glass of wine suppresses antidiuretic hormone secretion for approximately 2 hours, increasing urinary fluid loss beyond what the beverage volume replaces. Add 1 cup of water for every alcoholic drink consumed. NSAIDs, ibuprofen, naproxen, which suppress prostaglandin synthesis and reduce renal blood flow as we covered in the blood pressure medications video, should be accompanied by an additional 1 cup of water per dose when they cannot be avoided. And high-sodium foods, processed meats, canned soups, restaurant meals, increase obligatory urinary sodium excretion, and with it obligatory fluid loss. Add 1 cup of water per meal containing more than 800 milligrams of sodium. The counterintuitive claim at the center of this video is the one that most directly challenges what adults over 60 have been told by their physicians in the context of kidney disease. When a physician tells an adult with declining GFR and mild ankle swelling to limit fluid intake to avoid fluid overload, that instruction, applied without distinguishing between interstitial fluid accumulation from cardiac or venous insufficiency and the circulating volume deficit that impairs glomerular filtration, can accelerate the very kidney decline it is intended to protect against. The clinical situations are distinct. Fluid overload from cardiac insufficiency requires fluid restriction and diuresis. Glomerular hypofiltration from chronic inadequate fluid intake requires the opposite intervention. Both conditions can produce ankle swelling. Both conditions can occur simultaneously in the same adult over 60. A patient who receives the instruction, limit fluids, without the clinical nuance distinguishing cardiac fluid overload from renal perfusion. Insufficiency may reduce their fluid intake in a situation where increasing it would have preserved 10 years of kidney function. This distinction requires more than 15 minutes of appointment time to communicate accurately. It rarely receives that time. The 25-year economic comparison between the hydration protocol and the pharmacological and procedural trajectory of chronic kidney disease progression is the most direct cost arithmetic in this entire video series. The complete daily hydration protocol, room temperature water, a trace of mineral content, timed across 8 drinking intervals, costs under $1 per day at standard municipal water rates. Over 25 years, the total protocol cost is under $9,000. Compare that to the treatment trajectory for the 31% of adults who, according to the South Korean cohort data, would have avoided progressing from CKD stage 3 to stage 4 if they had maintained adequate fluid intake across 8 years. The United States Renal Data System's 2023 report places the average annual treatment cost for CKD stage 4 at $32,000. End-stage renal disease requiring hemodialysis costs $96,000 per year. A kidney transplant costs between $350,000 and $500,000 for the procedure, plus $30,000 annually in immunosuppressive medications thereafter. The pharmaceutical and medical device industry generates over $200 billion annually from the global management of chronic kidney disease across all stages. There is no product, no prescription, no procedure, and no billable clinical event tied to an adult over 60 drinking 2 liters of room temperature water distributed across 8 scheduled intervals every day. The intervention that the evidence most strongly supports for the most common modifiable cause of kidney function decline in the aging population costs under $1 a day and generates zero revenue for any company. Right now, a 69-year-old man is on his 3rd cup of coffee this morning. He has had nothing else to drink since waking. His last GFR reading was 58, chronic kidney disease stage 3. His physician told him to watch his salt intake and come back in 6 months. He will drink approximately 3 to 4 cups of total fluid today, as he has every day for the past decade. He does not feel thirsty. His hypothalamic thirst receptors have declined in sensitivity sufficiently that the 40% fluid deficit he is operating under produces no meaningful urge to drink. His tubular cells are performing maximum intensity concentration work this morning, as they have every morning, demanding that 1 million nephrons, already reduced to perhaps 700,000 by normal aging, compensate for a fluid volume his kidneys were not designed to filter without. He was never told that the single most impactful change he could make for his kidney function this week costs nothing, requires no prescription, and has been documented in Japanese and Korean nephrology research since 1998. Press the like button right now. Without it, YouTube buries this video and he never finds it. With your like, this reaches 100,000 people. Every week I release the research your doctor did not have time to cover at your last appointment. Subscribe so you receive it. Share this with the adult over 60 in your life who has been told their kidney function is a little low and was sent home with no specific guidance about the most evidence-supported intervention available for slowing that decline. How many cups of fluid do you drink daily? Honestly? Tell me in the comments. And tell me, has your doctor ever asked you that question at a kidney function appointment? Yes or no? I deliberately left out the specific morning hydration timing protocol used in Japanese hospital nephrology wards that the research shows produces measurably better GFR preservation than standard hydration advice. Tell me in the comments if you want that next. The visuals in this video are AI-generated animations used only to illustrate the content. They do not affect the accuracy of anything presented here in any way. Every study, every clinical finding, and every protocol detail was personally reviewed by me before it became content. This channel exists for one reason: to give you the knowledge to walk into your next appointment with the right questions, because a routine visit does not always have time to cover every risk your daily habits carry. Dr. Jae Yoon. The science Asia has always known. Take care of yourself. I mean that.